Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse, Transplantation, Marcus at Home welcomes Professor von Veldhuisen in Groningen, Netherlands, and Professor Udo Bavendiek in Hannover, Germany, to talk about Digitalis. Dear Professor von Veldhuisen, dear Professor Bavendiek, we're honored to host you, one of you for the second time. Just as a quick introduction, Dr. van Veldhuisen is Professor of Cardiology at the University Medical Center Groningen in the Netherlands and lead author of the just previously published Decision trial. And Professor Bavendiek is Professor of Cardiology at Hannover Medical School, Germany, and lead author of the Digit-HF trial, which we've already discussed here earlier. And we're very happy to have you both together to see what Digitalis will be worth for us for heart failure therapy in the future.
So, dear colleagues, it's a big pleasure for me to discuss today the place of Digitalis glycosides in heart failure. And so I will first present the results of the decision paper, then we'll do the meta-analysis. So the background of doing the decision trial is that about 30 years ago, a big trial was published in the United States called the DITCH, and that was a study in about 7,000 patients with heart failure with only background therapy of diuretics and ACE inhibitors. And that study had as its primary endpoint all-cause mortality. Now, the study did not reach its primary endpoint, it was not statistically significant because there was no effect on all-cause mortality, but there was a significant 25% reduction of death or worsening heart failure, and that effect was the endpoint we use these days for big trials. But at that time, the study was considered negative or neutral. Not negative, but neutral. However, a couple of years later, there were some sub-analyses from the DITCH study and in about 1,000 patients, and they looked at the importance of serum digoxin concentration in the DITCH trial, and they showed that, in fact, if the dose was high and the levels were high, more than 1.0 nanograms per milliliter, that was, in fact, it was not doing well and was causing an adverse effect. But in fact, on the contrary, when the dose was low, 0.5 to 0.9, so low dose digoxin, in fact, it did have a very beneficial effect on outcome, statistically significant. But of course, that was a sub-analysis, and that study has never been conducted. Now, of course, last year we had the results of the Digit-HF trial from Germany with low-dose digitoxin, and we'll hear about that later. So the aim to do the decision trial in the Netherlands was to investigate the effect of low-dose digoxin against the background therapy of contemporary heart guideline-directed medical treatment in patients with heart failure with mildly reduced ejection fraction. So that's less than 50%, and that's a bit different than the Digit-HF trial because that only enrolled patients with less than 40%. So this was a prospective randomized double-blind placebo-controlled trial, also on the NCT trial guideline website. And we tried to achieve low-dose digoxin levels of 0.5 to 0.9 nanograms per milliliter. We tested these measurements every 6 months, blinded, so we didn't know which patient was having which. And this was done according to an algorithm, and the serum concentration was checked blindly and repeatedly. So we had the usual in- and exclusion criteria. Patients were more than 80 years old. Of course, they had symptomatic heart failure, mostly class 2, but also class 3, and the ambulatory class 4. We didn't get those patients. Ejection fraction less than 50%, what I said before, and we additionally had serum anti-proBNP concentrations, and they were dependent on whether there had been a hospitalization for heart failure within the previous year. And if they didn't, the criteria for sinus rhythm and AF were slightly higher, and of course in AF criteria were higher too, because in general levels are high in patients with AF. And in addition, patients had to be stable on guideline-directed narcotic therapy for at least 2 weeks. We had exclusion criteria. Patients had to have a heart rate more than 60 if they were in sinus rhythm, and more than 70 if they were in AF, because the digoxin obviously lowers heart rate, particularly in AF patients. GFR, renal function, should not be less than 30 milliliters per minute per 1.73 square meters, and there were some additional inclusion criteria as well. So the primary outcomes of decision and the sample size calculation was as follows. A primary endpoint was a composite endpoint of CV mortality and total worsening heart failure events. And that is different than the Digit-HF study because we counted all additional events because patients are a long time in the study, and if they would have a heart failure hospitalization after 3 months, you reach a primary endpoint and you would lose some statistical power. So that was defined as a total hospitalization, total urgent hospital visits for worsening heart failure, and that was defined that you needed IV medication. Secondary outcomes were components of the primary outcome, but also time to first event. So that was similar to the Digitalis trial, and also all-cause death, etc. Now, the power calculation was as follows. We assumed that we would have 18 events per 100 patient years. So in 100 patients who were in the study for a year, we expected 18 events. And we assumed a risk reduction of 22% with low-dose digoxin. It was based on the DITCH trial, but also on the CHARM Preserve trial. And with that, we had an 80% power, and we needed 982 patients. So these are the baseline characteristics. There are two groups, digoxin and placebo, both about 500 patients. The mean age was about 72, 73 years. So it's somewhat older than the previous Digitalis trials. We had 28% females, slightly higher also the other trials. Most patients were in class 2, as you can see, about 88%. So there was more milder heart failure than the other trials as well. Ejection fraction had a mean of 33%, a bit higher too. And we also had about 20% of patients between 40 and 50% with mid-range ejection fraction. Now, these patients were on maximum NT-proBNP was about 1,400 picograms per milliliters. And these patients were on guideline-directed medical therapy. So that's a beta blocker in about 87% of patients, an ACE inhibitor or an ARNI, mostly ARNI, in about 90% of patients, an MRA in about 72% of patients, and an SGLT2 inhibitor of about 41% of patients. And patients also had ICDs and CRT. So this is the primary outcome. What you can see on the right side is that in the placebo group in red, there were 19.3 events per 100 patient years. So in fact, that was slightly higher than what we felt that the event rate would be. So that was okay. And there was, as you can see, there was a risk reduction of 0.81, which means 19% risk reduction. And so the study was not statistically significant, despite this pretty significant effect of 19% reduction. But we aimed for 22%, so the trial was not statistically significant or not conclusive, if you will. Well, these are the components of the primary outcome, because it's known that Digitalis glycosides particularly work on heart failure worsening and may have less of an effect in CV mortality. We'll hear about that later. On the left side, you see the heart failure worsening events. So hospitalization, urgent hospital visits. In fact, there were only 11% urgent hospital visits. And here we see a rate risk reduction of 0.76. So that's a 24% risk reduction, also not statistically significant. And on the right side, you see CV mortality with the hazard ratio of 0.93, and that's also not statistically significant. So now we look at subgroups, and in fact, I can say that there was nothing different in any of the subgroup we tested, but I would like to take your attention to 3 different subgroups. First of all, female patients. Of course, in heart failure trials, you see many fewer patients, female patients and male patients. We did everything to get a significant number of female patients. We ended up with 28%. And in fact, what we see is that when you look at the rate risk reduction, is 0.71 in female patients and 0.85 in male patients. This was not statistically significant for a p-value for interaction. So, in fact, no significant difference, but in fact, reassuring values. And this is important because the old DITCH trial had shown that possibly in the female patient there would be an adverse event. So we didn't see that. Now, secondly, of course, sinus-driven atrial fibrillation. We had 29% patient atrial fibrillation. And what you see here is that, in fact, in AF, you see there's a rate risk reduction of 0.76 and in sinus-driven 0.82. So, in fact, a better effect, a slightly better effect, if you will, in AF patients, but not significantly different, and p-value also not statistically significant. So the drug works basically similar in AF and sinus rhythm. Now, another important factor, of course, is whether the drugs works on top of maximal medication, because remember, in the DITCH trial, there was only ACE inhibitors at background therapy. And what you see is that quadruple therapy as compared to no quadruple therapy. You see that quadruple therapy, the risk rate reduction is 0.72 as compared to 0.82. P-value for interaction not statistically significant. So very reassuring findings. So now we look at safety. Safety is important, of course, because in the past, with the higher digoxin levels, there were safety issues and DITCH toxicity. And in particular, you see when you look at adverse events, it's particularly usually digestive. Patients have nausea and vomiting. We did not see anything like that. We did not see any effect of the digoxin in these patients, very reassuring data. The other thing, of course, is whether, of course, Digitalis may have an effect on the conduction system. So it has been suggested that maybe we would need more pacemakers. If you look here, you see that in the digoxin and placebo groups, there's absolutely no difference in terms of pacemaker, backup pacemaker, but also not ICDs and CRTs. So no GE problems and no increased need for pacemakers. But we did, in fact, have quite a few patients that discontinued study medication for all kinds of reasons, usually because they felt the study was becoming too much. We had a mean follow-up of 3 years and some patients in the study for 4.5 years. We're elderly population, and we also suffered from the COVID pandemic, of course, and we lost more than 20, and at the end of the study, more than 20% of patients had discontinued the study medication. So we also did an analysis with on treatment, and of course, one may have a lot of arguments against that, because that, of course, is bias in a way selection, but it gave us an idea. In fact, what we found here is a rate risk reduction of 0.66. In other words, there was a 30% reduction when patients were analyzed that were on the drug, and that was statistically significant. So in conclusion, low dose digoxin did not significantly reduce the primary compulsive endpoint of CV mortality and total worsening heart events with a rate risk reduction of 0.81. There was a non-significant relative risk reduction of 24% in worsening heart failure events, but also not statistically significant. But low dose digoxin was generally well tolerated and safe, also in women and in patients with AF. There was a relatively high number of study drug discontinuations in both groups, which led to a lower statistical power and which cost us, so to speak, statistical significance. But in the as-treated analysis, digoxin resulted in 34% risk reduction for the primary outcome, and DECISION is the first randomized clinical trial examining low-dose digoxin and will add importantly to the totality of data on Digitalis, glycosides, and heart failure. Thank you.
Thank you so much, Dirk. That was great. Should we just, before asking questions, go straight to the next presentation by Udo?
Good. So I think I can cut my talk a little bit because Dirk wants to present the meta-analysis and also some data from the withdrawal the results they have. So Dirk, you heard about, and basically what we did based on the DIG trial data, we decided to use not digoxin, but digitoxin, the other cardiac glycosides, which has a more stable serum concentration for pharmacokinetic reasons. And it's the other cardiac glycosides of clinical use in Germany at least, but also in other countries together with digoxin. But there are no clinical trial data about digitoxin use in patients with heart failure and reduced ejection fraction. And because we aim to perform a really simple clinical trial, we also choose digitoxin for this reason, because it's much easier to handle, because if the serum concentrations are stable, stably titrated, you do not have to perform repetitive serum concentrations, because even with worsening renal function, the digitoxin serum concentrations are quite stable. So you do not have the problems as with digoxin, that the serum concentration are increasing with worsening renal function. That's just a summary. That's the main difference regarding pharmacokinetics of digoxin and digitoxin. The elimination point is the most important. So digoxin is mainly eliminated by renal pathways, and when renal function is impaired, then digitoxin can be eliminated can be eliminated by the enterohepatic pathway, and this is completely compensating the elimination process even with advanced renal function. So we aim to perform in DIGIT-HF a simple and large trial approach to investigate if digitoxin with low serum concentrations accordingly to the digoxin serum concentration. We calculate this from pharmacodynamic data, which are like 40 years ago, on top of standard of care of a well-implemented guideline-directed medical therapy. We would like to demonstrate that digitoxin in this condition reduces a composite of all-cause mortality and hospitalization for worsening heart failure, whichever occurs first. It's a little bit different than the DECISION trial, as Dirk mentioned, where there was a repeating event analysis, but basically we have the same. Okay, we randomized 600 patients in each treatment arm. Inclusion criteria were patient with heart failure with direct infection, a little bit different compared to decision. So we included patients. They have to be in New York heart association class 2 if they were with a left infection of lower or equal 30%. And they have to be with a clinical more symptomatic heart failure burden, means New York Heart Association class 3 to 4, if they have a direct infection up to 40%. They have to have a very well implemented baseline heart failure therapy recommended by current guidelines, at least for 6 months. Importantly, also sinus rhythm and atrial fibrillation patient can be recruited, which is different to the DIC trial, as Dirk mentioned, which only recruited sinus rhythm patients. And the main exclusion criteria was the treatment with amiodarone, because this is competingly metabolized in the liver, causing high cardioglycoside levels if you have concomitant therapy with amiodarone and digitoxin. And we also have a safety heart rate of below 60 beats per minute for exclusion. And after recruitment, patients received a status of 0.07 milligram digitoxin. Serum concentration are controlled after 6 weeks, and then we titrate the dose to, if necessary, down to 0.05 milligram digitoxin or up to 0.5 milligram, or we keep the 0.07 milligram dose. And then the patient ran through the entire trial, even up to 8 years follow-up without any further concentration checks. So recruited in total around 1,300 patients, and the baseline characteristics were well balanced. We have 66 years in average, a little bit younger than decision, and also as we expected. 70% of patients were in New York Heart Association class 3. Ejection fraction was 28%. In average, 30% had atrial fibrillation, which is important, and the renal function was impaired with a mean eGFR of 65 milliliter per minute. Importantly, similar to decision, we have a very well implemented guideline recommended medical therapy, almost 95% beta blockers, 95% RAS inhibition, 40% ARNI, 76% MRA, and 20% SGLT2 inhibitors, and which is typical probably for German patient population. We have a very high treatment with device therapy, 65% ICD, and CRT with 25%. So in total, a very well treated heart failure patient population. So and that's a primary outcome. The primary outcome was death from any cause or first hospitalization for heart failure, as I mentioned, and this was significantly reduced with a hazard ratio of 0.82, means a 18% risk reduction, which is absolute risk reduction of 4.6%, number needed to treat of 22 over median time of follow-up 36 months. And the treatment of the was driven by both components of the primary outcome, equally by death from any cause and first hospitalization for heart failure with a risk reduction of about 15%, both by themselves not significant, most likely because of the number of patients, but both components went in the same direction, fitting to the primary outcome. So we have also key secondary outcomes, and altogether they support the primary outcome results. Basically, they are all reduced in a similar way, about 15% risk reduction to key secondary outcomes like total numbers of deaths from any cause in heart failure hospitalizations or deaths from cardiovascular causes or first heart failure hospitalization, which are the typical heart failure endpoints in modern heart failure trials. but this was also not significant. However, the point estimates were similar compared to the primary outcome result. And if you look for the subgroups, Dirk also mentioned some of them. Sex was an issue in the DIC trial. We have also no indications that female patients have any harm in the trial. Patient with New York Heart Association class 2 or 3 or 4, similar treatment effects, and also atrial fibrillation, which is, besides decisions, the first trial which included patient with atrial fibrillation in the cardiac glycoside trial with HFrEF, and we also see basically similar treatment effect. And we subdivided a little bit this and just showed this as the ESC Heart Failure Congress, just to let you know that it looks like that the patient with atrial fibrillation, if you look for the primary outcome and the Kaplan-Meier curves, they have an advanced or more pronounced treatment effect for the primary outcome. If you look at the hazard ratios, but especially at the absolute risk reduction of 10.5% compared to 2.8% with patients with no atrial fibrillation. It's the number needed to treat of 10 versus 36, but however, this is of course exploratory, but still there is a quite a strong signal that patients probably, especially with patients with atrial fibrillation, might have more beneficial effects on the primary outcome. And if you dissect this further to the components of the primary outcome, it seems or it appeared that patients with atrial fibrillation may have beneficial effects regarding mortality compared to patients with no atrial fibrillation by digitoxin. And this in total are very important data. And we can surely interpret this that patient with atrial fibrillation can be treated with digitoxin in a safe way, which is important, of course, because we often have to use this for rate control, and there's no issue about harm or concerns about toxicity as described in previous trials, which mainly used registry data or post-hoc of other trials. We have some indications that some other subgroups might, in particular, benefit from digitoxin treatment. So patients, if you look at the point estimates, patient with non-ischemic disease, patient with a higher heart rate, patient with a lower blood pressure, they may have more benefit from digitoxin, but we have to analyze this, of course, in more detail. Importantly, patient with impaired renal function also demonstrated a comparative treatment effect compared to the overall treatment trial result. And importantly, similar to the decision, also patient with a modern heart failure therapy, including ARNI, SGLT2 inhibitors, triple therapy or quadruple therapy. So fantastic for they show similar treatment effects for the primary outcome with digitoxin. Serum concentrations where titration of the digitoxin dose worked well. So as I mentioned, we just adjusted the dose at 6 weeks, and we started with a mean serum concentration of 17 nanogram per milliliter and went to 13, which is exactly in the target range we would like to achieve. So this was working nicely. And finally, we also made some recommendations regarding dose titration in patients with female sex, patients which were older, have a lower eGFR or low BMI. You should start with 0.05 milligram digitoxin, and the others with 0.07 milligram. Thanks.
Yeah, thank you, Udo, very much. Should we go straight forward further to the meta-analysis?
Okay, so I will now speak about the meta-analysis of 3 trials, DITCH, DIGITA-F, and DECISION. So the rationale to do this, with the publication of DIGITA-F and DECISION, there are now new evidence have now become available in heart failure patients receiving contemporary background therapy. The DITCH trial was conducted in the beginning of the 1990s, so more than 30 years ago, and published in 1997. And DIGITA and DECISION were both relatively small compared to DITCH because they had 1,000 to 1,200 patients. They are different types of Digitalis glycosides, but they, in large part, they have a very similar mechanism of action. There may be some pharmacokinetic additional differences. And of course, there was a reduction of the primary outcome Digitalis, but not in decision. So the aim was to meta-analyze the effect of Digitalis glycosides in patients with heart failure with mildly reduced ejection fraction. So this was a systemic review, which was prospectively defined and laid down on Prospero site. We defined that large RCTs with more than 1,000 patients before we knew the results of the trial, testing long-term the effects of Digitalis glycoside therapy in patients with HFrEF or mid-range F. We had a pre-specified primary composite outcome to make them all equal. So this time we had time to first event, first worsening heart failure or CV death. And it was this had a fixed effect model, with all the sensitivity analyses. I'm not a statistician, but it was a random effects model, and it compared for treatment era, but also for type of Digitalis glycoside used. So what do these trials look like? We already heard about decision and Digitalis, so that's new. But of course, in decision it was decision all levels, so it was higher levels and also lower levels. Ditch had, in fact, I'm sorry, it said decision, but Ditch in fact had all kinds of levels. It had an ejection fraction less than 45%. All patients were in sinus rhythm, and in fact, patients with New York Heart Class 1 to 4 were all accepted for their trial. And we heard about the inclusion-exclusion criteria about the Digitalis and decision. Primary outcome for Ditch was all-cause death that we discussed before, and we heard about the other two trials. And mean follow-up was around 3 years for all the 3 trials. So how did the baseline characteristics of 3 trials compare? Like I said before, Ditch had the youngest patients, and that again 30 years ago. So the general, your average heart failure patient was then a lot younger than what you see today. It was mostly post-myocardial infarction, of course, younger patients, elderly, but people in general were, of course, not getting as old as they do today. Digit had a mean age of 66, and we had 73. It says 73 with 73. Ditch had 22% females. We had Digitalis had 20, and we had 28. Ejection fraction was also much lower in the 2 trials, and decision was higher. Diabetes, stroke, atrial fibrillation was 0 in Ditch and comparable in Digitalis and decision. And background therapy again was only ACE inhibitors in Ditch and was much more contemporary in the other 2 trials. So this is the primary outcome for the Prospero meta-analysis that we defined. So if you look at the primary endpoint CV death over first worsening heart failure event, and I didn't report that yet for decision, that was 0.83, so very similar to the Digitalis. Very similar findings, and in fact, very similar for the 3 trials. But of course, you see with 6,800 patients, your confidence intervals are much smaller, as you can see here. So when you put them all together, you see the overall result is 0.85. So the 3 trials combined together in a meta-analysis show 15% reduction in the primary endpoint of CV death or first worsening heart failure events. And there was no statistical significant heterogeneity in these trials, and it's highly statistically significant. So when you look at the secondary endpoints, so that's worsening heart failure, first worsening heart failure event, or all-cause death of first worsening heart failure event, you see that these drugs mainly work on heart failure worsening, as you can see here. And in fact, when you pull them all together, you see a hazard ratio of 0.75. So that's a 25% reduction in worsening heart failure events. And when you look at death or first worsening heart failure events, it's a 15% reduction. When you take all-cause death instead of CV death, it's a similar finding of about 15% reduction. Now, when you look at CV death alone, the trials are also quite similar with wide intervals of the 2 smaller trials, as you would expect, because the death rate is much lower, of course, in Ditch. And in Ditch, there was no effect. And when you put the 3 trials together, the hazard ratio is 0.99, so no effect. And very similar not only for CV death, but also for all-cause death. Now we get to the sensitivity analysis of the primary outcome, and we first look at the digoxin versus digitoxin. And you see here, you see the Ditch study in decision, that is digoxin, and Digitalis digitoxin. You see the effect of the 2 digoxin trials, and this is all doses, and Ditch decision only low dose. You see an effect of the primary outcome of about 15%. Whereas what you see with digitoxin in the Digitalis study is exactly the same, also 15%. Now, if you look at the contemporary background therapy as compared to the early days in the DIG study, now the DIG study was only ACE inhibitors. The effect of the primary outcome is 15%. When you look against the background of the Fantastic Four and device therapy, you see that the all size effect is 16%, so exactly the same. So it doesn't make a difference if you have a big, wide background therapy of Fantastic Four, or whether you have hardly any treatments, there's no effect. And there's no statistically significant heterogeneity, and the effect of Digitalis, like a versus placebo and Digitalis in decision, was statistically significant with a hazard ratio of 0.84. So the conclusion of this study, in this meta-analysis of all large placebo-controlled RCT Digitalis glycosides and heart failure, we can say that Digitalis glycosides treatment was associated with a significant reduction in the risk of compositive CV death or first worsening heart failure events. This benefit was mainly attributable to a risk reduction of first worsening heart failure events without either effect on either CV or all-cause death. And these findings are consistent across the 3 trials, treatment era, and also type Digitalis glycosides. And these data support the use of low-dose Digitalis glycosides as additional medical therapy in patients with heart failure with ejection fraction less than 50%.
Thanks a lot, both of you, for that great presentation. And I think the key learning, maybe the key learning for our viewers who are not always familiar with cardiology and those topics, is that maybe old drugs deserve re-evaluation within modern trial design. I think this is a major fact which you both nicely showed to us. And with regard to on the first view, different trial outcomes, which you nicely sorted out in your meta-analysis, Dirk. This was a nice conclusion for that. There are different features which may account for that. And I have a question, and maybe you could answer first, Dirk, with regard to left ventricular ejection fraction, because in your trial it was different, and you even included heart failure with mildly reduced ejection fraction. And why was that? And at the end, do you think digoxin has a specific role in HFmREF?
Well, that's a very good question, and of course, it's been asked a lot of times. The new ESC guidelines on heart failure will probably change from reduced ejection fraction and mildly reduced and preserved to reduced less than 50% and preserved more than 50%. And that is also because what we saw in the past, and this is at the time of the DIG study, that basically almost all patients, heart failure patients we saw, had an old myocardial infarction, had low ejection fraction, and this is what we also at the time saw in the 1990s. Now that has radically changed. In Germany and the Netherlands equally, what happens is that we do an angioplasty PCI on myocardial infarction, and we see fewer patients with low EF heart failure and a bad systolic function. We see more patients with either EF between 40 or 50 or preserved EF, and of course, in preserved EF, there's a lot of adiposity as well as background pathophysiological problem. Now, we designed our study slightly later than our German colleagues. And at the time that was changing. So we felt that we needed to have some patient with mid-range ejection fraction as well. We knew that the event rate in these patients was lower than a patient with low ejection fraction. And in fact, this may be one of the explanations why the German study, which was also a bit large, it was 1,200 patients, we had 1,000 patients, but the event rate in the German study, in the Digitalis study, is also slightly higher than our study. And that cost us, so to speak, statistical significance. Having said that, we had a relatively high dropout too, and that probably had to do with age, but also with COVID. So we anticipated on more patients in the mid-range group, so to speak, and that's why we took these patients in. In the end, there were only 20%, but it may have affected the outcome of the trial.
Would you agree, Udo, or would you like to agree? Some comments to that?
Yes, I mean, at the end, you are always, you know it better, right? I mean, I'm sure if Dirk had known the result before, probably they would design it different. But that's how we have to deal with the data, and I think we have a really nice data set now. And of course, we will. I can mention this. We plan also an IPD analysis, but it was important to do the publication-based meta-analysis already to really stress that cardiac glycoside treatment is really coming back now, and it's an important option in patients, particularly in patients with HFrEF and atrial fibrillation. And so I think we have to interpret the data in more detail in the next years, and then we probably dissect which patient population particularly might have benefit in addition to the Fantastic Four, for example.
Can I add something to that?
Sure.
Yeah, can I add something? Well, the other thing you said, well, and it's correct, of course. If you look back, you think, of course and that goes in Germany too. If you would have done 2,000 patients, 1,500, you would have had more statistical power. With us looking back, we were extremely happy to get these patients in 3.5 years, but it was at the same time was enormous stretch because this is not a pharma supported study, and I know in Germany you have issues too with enrollment, and that is a big issue when you basically have to do it all yourself, so to speak. And so I really compliment my German colleagues for getting this done, so to speak, the study. And we had big, it was difficult to get the patient in. You have to do it all yourself. You don't have a big, powerful company behind you. And so even in hindsight, we knew at the time with the statistical power of 80%, it would be difficult. If you would have had 90% power, you would have had more chance. But that's just when you do an investigator-initiated trial. These are the kind of problems you are aware of.
That's a perfect thing there that you mentioned. I mean, you're very much to be congratulated, the both of you and the whole teams for just accomplishing these trials without industrial support. I mean, and this I think that makes a difference even in prescription everyday medicine, because there's nobody doing advertisements for these drugs. I was wondering to the two of you the question: is there a substance specific effect? I mean, we have distinct differences. We have some differences in the patient populations, but even in decision, I mean, the patients were quite sick. They had high BNP levels. Most of them had reduced ejection fraction, and the primary endpoint was neutral, as you just discussed on the statistics. Is there a drug effect as well? And that also alludes to the fact that digitoxin, as Udo has said, is available in Germany, but almost nowhere else in the world. And I know people from the United States and other places are quite critical with that.
Yes, I mean, of course, we were asked from several countries already regarding availability, but probably there's something happening now with the pharmaceutical companies. There's some companies trying to get the approval back, which was available in the US. So you do not have to apply completely from scratch. So you just have to, get the approval back, which was putting on hold so far. So we will see in India and China and also other countries like Africa, for example, might be important in general because the drugs are very cheap. And for me, I'm wondering a little bit regarding difference in the drug effects. Probably Dirk can answer this at least in the low digoxin concentrations, serum concentrations. Of course, it's post-hoc analyzed in around 1,200 patients or 1,500 patients. You see a strong effect on mortality also, but you do not see this in decision. So do you have any idea why this could be? I mean, we also sometimes, of course, we wonder if we would have recruited 2,000 patients as initially planned. I'm sure we should have reached a statistical significance with the mortality outcome, but of course we didn't do it, so we have to deal with that. But that's for me one of the biggest difference, and probably there are difference in the compounds even. Also, we do not expect that primarily.
Well, I tend to have a little bit of a different view. Udo and Johan and us in the Netherlands agree on a lot of things, but I don't think there's any evidence that digitoxin is better than digoxin, and we will never get that answer. There will never be any head-to-head comparison because both drugs are, of course, not commercially interesting, so to speak. The thing is that, again, there's pharmacokinetic differences, but the main selling point, so to speak, for digitoxin would then be that it's easier, but we have done about 3,500 measurements, and we have that data. We will possibly present it in Munich, München, at the ESC. And it's enormously simple to do this. You have an algorithm based on age and renal function, and you have your almost all patients. In fact, we were on the low side. Our mean level is 0.62 or so, and it's about similar in men and women. So we in fact would have some window before we get to the upper limit of 0.9. So we might even get a bit higher. It's extremely safe, and I've also seen data now that's not worked out yet, but also when you're in that range, you do extremely well. When you're outside, we hardly have any patients above 1.2, just a few patients, and I think 1 or 2 patients above 1.5. So in terms of safety, it's extremely safe to use the digoxin too. And then again, digitoxin is a positive trial. Our trial with low dose digoxin is not. But there are no data also in the world saying that the clinical effect of digitoxin would be better than digoxin. But having said that, it's a fantastic trial. I don't want to argue about that, but the evidence in the world that's been accumulated over the past 30 years for everything, and again, there have not been that many studies with digoxin after the DIG trial, are all done with digoxin. So I think as good as a drug it is, obviously digitoxin, I think it's a very good drug, but I think it's very similar to digoxin. I don't really, and pharmacologists tell me that too. So they're both good, but I do not think that digitoxin is better.
I didn't say that. We have some data that there are differences actually on vascular effects from our own lab, but that's of course lab work, and let's see. I mean, basically I think we can use of course in Germany we would prefer digitoxin. Of course we have a positive trial,
yeah.
But you have to analyze or interpret the whole data set which is now available. Yeah.
But it may be not so important also because I think they're both great drugs. If in one country digitoxin is on the market, the other one digoxin is on the market, that's fine. I mean, and the good thing is that these drugs work differently. It doesn't lower blood pressure. It's amazing the results with blood pressure baseline. Patients, in fact, they slightly increase their blood pressure. We have this withdrawal rate where you see that the patients, once they stop the digoxin, their blood pressure goes down and the NT-proBNP go up. So this drug sort of stabilizes your autonomic function, in my opinion, which is a very good thing in heart failure. It's strong vagal effects when you look at heart variability. It lowers catecholamines. That's exactly what you want in heart failure, and I think both drugs do that. So I think they're both fantastic drugs.
As a nephrologist, I have to ask this question. What do you would like to recommend for our patients with CKD, advanced CKD, even below 30, eGFR of 30, or maybe on dialysis? We have so many patients suffering from heart failure and advanced kidney diseases.
Well, that's obviously a very good question, and that's something we did not investigate. We did not want to have patients below 30. I think if they're on dialysis or close to transplantation, I really wouldn't know. But I think there, obviously, the digitoxin would seem to be the more logical choice. I think because it's not clear it's also clear by the liver. So, but I'm not sure if there are data to support that indication. But it would seem more logical, so to speak.
Yes, that's an important point. We have to analyze the renal data, of course, in more detail. But so far, as I said, we did the dose titration once, and that's it. And even we recruited patients with eGFR below 30. But of course, we have to check that. To be honest, I think you can start digitoxin even with a patient with terminal kidney disease, but you should check the serum concentration, of course. This I would definitely do, at least in particular if you are females and you have a low body weight, because then we know the distribution volume is just too low, and you have also increased serum concentration in this condition. So, but for me, of course, as Dirk already suggested, in this case, you should prefer digitoxin, for my opinion.
How many patients did you have in DIF that had a GFR below 30?
I have to check, actually. I cannot tell.
5 or 10.
But it's a significant number.
Yeah, so it might give you a clue how that works in those patients. So, and again, just to answer your question, patients with a GFR less than 30 are difficult also for MRAs. of course, and for armies. So it's a difficult patient category with a very high event rate. So if you have something that's safe there, it would be important, I think.
Yes.
Dirk, you and your colleagues presented some other data, and you put on the question how safe it is or how bad it is to withdraw the drug.
Yeah. So we knew that, and this will probably go for digitoxin as well. We knew that from the old studies in the 1990s, we had two papers, Radiance and Proof, that showed that, and then of course it was only against the background of ACE inhibitors. If you would stop the digoxin, and that was all doses, then you would get significant problems. And there's two papers that showed it in terms of clinical events, but also in terms of worsening exercise capacity, etc. So we said we will do the study, and we had about 600 patients, 580 patients still in the trial at the end of the study, the end of study visit. We said we will see all these patients back after 6 weeks, just to be safe. We didn't know what was happening. And in fact, the event rate before that was very stable. The 100 days before that, we used that as a background to see what the overall event rate, which was lower in the digoxin patient than the placebo patients. And then we stopped the medication. And then we saw them back after 6 weeks. Now, what we found is that there were, within those 6 weeks, 14 patients who earlier had digoxin who deteriorate, had worsening heart failure, as compared to only 2 on placebo. So, in fact, the placebo patients just went on as they did before the 100 days, which is logical because they were on placebo, so they didn't get anything. But the patient on digoxin, in fact, had many more. This was highly statistically significant, 14 versus 2. So a hazard ratio of 7. But they also had increase in NT-proBNP. They had lower blood pressure, renal function deteriorated, and it was one other thing. I forget. I think heart rate also went up again. So these are powerful drugs, and I think this will probably be the same for the digitoxin. And it's an indirect proof, basically, because you have a drug, you take them off, and they get into clinical problems. But many people, when we presented that data at Barcelona, said this to them was maybe the most convincing. And again, it's very low numbers. It's indirect evidence, but it will come in the European Heart Journal. And we think it's interesting. And we were glad that we made the agreement that we would see them back in a blind manner within 6 weeks.
Have you any data on that, Udo, as well? That might be really interesting to see that.
Yeah, it's a pre-specified analysis, and we do it a little bit different because we cannot do it as Dirk presented it, but we have a median follow-up of 18 months on treatment and 36 median follow-up total. So we have a lot of patients with a huge gap with like 1 or 1.5 year difference between treatment, end of treatment, and end of study. And in this population, we see them all. We saw them every 6 months, and we definitely will check for that. If we have any indications regarding heart outcomes, it's a little bit difficult to analyze. We have to prepare the models properly, but that's one thing we would like to do, and we will want to also check for the last 40 days. So we did not see them in person in a visit as in decision. And we did not do blood draws and things like that, but of course, we checked 40 days after end of treatment for the patient who ended the study until the end, if there are any side effects. And we have to see. So far, we have no indication for the withdrawal effect, but probably we will see.
But the way it's been exactly shown like this, also empagliflozin and dapagliflozin, when you withdraw these drugs, which are powerful drugs, you see a sort of rebound worsening heart failure in these patients. So it has been accepted by some people as some evidence for benefit.
I have one last question from my side. You both showed data on post-hoc sub-analyses of patients with or without atrial fibrillation. And if I got you correctly, then you do see quite a difference in the one trial and not at all in the other. Could you comment on that? Is it because obviously everybody in the practical world now thinks about who are the patients that I'll be giving digoxin, digitoxin to, and it's most likely those with more higher heart rate, atrial fibrillation, lower blood pressure, severe disease. But is it better in heart failure than in sinus rhythm or not?
You want to take that, Udo?
Well, basically, you know this post-hoc analysis of the beta blocker trials, which basically showed the neutral effect with beta blockers compared to sinus-rhythm. Of course, it's all post-hoc, but I think it's was important analysis. And so far, both trials show a clear treatment effect in patients with atrial fibrillation. So, of course, they are all on beta blocker therapy with 95% background therapy with beta blockers. But I think it's a very, very important option now, and it's good to know that it's definitely safe to treat patients with atrial fibrillation with HFrEF, which have a worse prognosis, to treat them for rate control or even for prognostic reasons. We don't know, of course, with cardioglycosides. And for me, it's important because when we started the trials, we struggled with a lot of post-hoc analysis or secondary analysis of this registry data. All showed that patients with cardioglycoside treatment had a worse prognosis, and it's just an association, as we showed in the European Heart Journal paper with the reanalysis of the DIG trial. It's clearly a treatment bias effect, nothing else, no causal relationship.
Yeah, absolutely. I agree with that. As a matter of fact, we also have looked at the AF data and decision, and what you see is that with the low dose digoxin, you see a decrease in heart rate of about 7 beats per minute as compared to 1 and 1.5 in the sinus rhythm group. So this drug really works on the AV node. And of course, heart rate reduction is very important target in AF therapy, and it's been used also more in AF heart failure patients and sinus rhythm heart failure patients, and has a higher ESC recommendation, also 2A instead of 2B for sinus rhythm. So I agree with Udo. I think it will at least be as effective in atrial fibrillation.
So for the sake of time, I think we have to wrap that up. And one quick last question for our community with a quick answer, maybe a quick answer. So Mark Pfeffer brought about this term of digitalization. How should we digitalize, or should we digitalize, again, a term that we that is associated with totally different facts today. So to both of you, and from your clinical point of view, on a day-to-day base, whom should we digitalize, or who do you digitalize?
Dirk, you want to go first?
Well, we've all been in all these radio interviews and newspaper things, and in the Netherlands you have a pretty strong GP organization. So people first go to the GP before they come to the hospital, and people said, "Oh, it's so simple, you can go to the GP." I said, "No, absolutely not." Because it's still a serious disease. You know, when you have 4 drugs and you give these well, first of all, we have to wait for the ESC guidelines that will come out in end of August, in September. I think there will be an enhanced recommendation, and for sinus rhythm also not 2B, but maybe 2A. So the evidence is accumulating. But I think, it looks like, and again, we don't have detoxing in the Netherlands, so I just talk about digoxin. Low dose seems very safe, and we'll come up with this data later. We talked about low GFR, that's a different story, I think. But I think in general, I think we will see a pickup of digoxin when I only speak from the Netherlands in the next few years, because this looks pretty convincing, and a lot of people, and in fact, many patients also said they felt better in the study, and we now know that they were on digoxin, but that's all NS1 evidence. But I think, and in Germany, probably you will see an increase in detoxing also, because it's probably also around 15 or 20% in Germany or so.
Yes, and we will look for that, definitely. Just quick answer, which patients I would like to treat with digoxin in my outpatient department, for example, patient neurocardization class 3, if they have the other contemporary medicine on board, patient with low blood pressure who probably cannot tolerate other drugs like RAS inhibitors, worst kidney function, MR antagonists, for example. So all these comorbidities which affect the treatment options for the other drugs, I think these are really good candidates, and patients with advanced heart failure. So there's huge interest also if patient with advanced heart failure also going probably for listing for heart transplant, if you could extend the time to vet implantation or transplantation need by cardiac glycosides.
Thanks a lot for those insights. It was so great to have you both today, Dirk in Groningen and Udo in Hannover. And hopefully, and maybe see you next time on this channel.
Thanks a lot. It was a pleasure.
Yeah, thank you. Bye-bye.